Assalamu alaikum wa rahmatullah. Good evening, everyone. First, I'd like to thank our professor and mentor, Dr. Mahmoud Salah. Also, I'd like to thank Dr. Ahmed Sakr for this opportunity. This presentation is supposed to be with Dr. Khalid Idris. Unfortunately, he couldn't make it to the conference, so I'm be honored to do the presentation for him. This is about heel ulceration in diabetic foot by Dr. Khalid Idris, consultant pediatric foot and ankle surgeon, American board in diabetic foot wounds. In this presentation, we are going to do some refreshment, doing spotlights on important items in heel ulcer management. First, we have to know the blood supply to the heel. Of course, we all know that it came from the calcaneal branches, from the posterior tibial and peroneal artery. Because when we come to an ischemic heel ulcer, we have to make some respect to the angiosome. Of course, if there is many tissue loss involving more than angiosome, we have to be aggressive in revascularization to involve the pedal arch as well. If the heel ulcer is showing bone or it's probed to bone, so it's osteo. You don't have to do any further investigation to make sure there is an osteo. Okay, the picture on the right side shows the most common sites for pressure ulcer. We can all notice that heel account 30% of pressure ulcers. But why heel ulcer is considered a difficult one? If an ulcer to the toe happens, big deal. The worst scenario will be toe amputation. If it's more extensive in the forefoot, also big deal. The worst scenario will be TMA. But when it comes to the heel, it's big problem. It may end up with major amputation. Actually, more than 50% of people with osteomyelitis of the heel will undergo high level of amputation. Also, heel pressure ulcer occurred in 70% of people undergoing orthopedic procedures. So, how do heel ulcer happen? By pressure, trauma, keratosis, and fissures. Keratosis will predispose to subcutaneous hemorrhage or strokes, will predispose to ulcer, and eventually lead to infection. Can anyone notice any abnormalities in the foot or the footwear? If you could realize that there is folding in the blue sheet, with chronic use, it will predispose to keratosis. And with debridement of this keratosis, we will find subcutaneous hemorrhage, which is predisposed to the heel ulcer. Also, footwear predisposed to the heel fissures, which predispose also to heel ulcer. Dr. Idris showed that 62% of ulcerated patients use traditional footwears. How will you manage the heel ulcer? If a patient like this picture came to your clinic, presented to your clinic, what would you think? Is it an ischemic ulcer? Is it a bit sore or pressure ulcer? Is it a burn? Is it a trauma? What is it? So meticulous history taking and physical examination is very important in diagnosis and proper treatment. If it's in ischemia, you will reserve it with revascularization. If it's infection, you will control infection by debridement of the necrotic soft tissue as well as bone, and eventually you will do wound care with negative pressure wound therapy and of course offloading. In this slide, I would like to say whatever the maneuver you will do to manage or treat the heel ulcer, it has to be followed by offloading. We have many methods of offloading like these methods, but just take care that there is no adverse effect for the method you will use. Like this picture, the wheelchair can also predispose to a pressure ulcer in the heel. There is a total contact cast with a window for allowing us to make dressing on the heel ulcer. There is also a heel wedge shoe, which is not very effective, but we can use it in a minor cases. The heel pillow itself is effective for transfer and prevention. A patient presented to your clinic like this, you will, after physical examination, history taking, good pulse, check the pulse, it's good. So it's a pressure ulcer. You will do some debridement. Of course, the picture in the middle show partial skin necrosis at the periphery and complete skin necrosis at the center. But with good debridement, good wound care, it will heal eventually. Why not amputation? Mortality within 30 days of hospital discharge was 9%. Hospital readmission near 30%. Above or below knee amputation, recovery more slowly and failed to return to the baseline function by 6 months. There is many kind of amputation, like Dr. Abdurrahman demonstrated. We have a metatarsophapharingeal amputation, we have a transmetatarsal amputation, we have a less frank and Schubert amputation. Just there is one more not discussed commonly, which is heel amputation, or what we say calcanectomy, partial or total calcanectomy. Here is a picture of a patient underwent partial calcanectomy with coverage of the part of the raw area with skin and the other with skin graft. After this is the picture or outcome after a heel amputation. This is another case with ischemic heel ulcer. First we do angioplasty, then we do some debridement, and of course with offloading and proper wound management, it will heal. This what happened after a debridement, partial calcanectomy, offloading, negative pressure wound therapy, and eventually the patient must do a custom-made footwear and possible foot orthosis. Okay, when we say it's game over for salvage, when there is a pus in the subtalar joint or ankle, what if the tendon Achilles is involved in the or infected? We must resect it total from the origin in the calf. And lastly, we'd like to announce that our maggot therapy lab will be launching very soon, about 2 months from now, which will provide us another modality for wound debridement.